Sound check, sound check. Hi, folks. Professor Bellaford here. We're going to do a clinical simulation review. This will be the part 2 video. If you do not have the part 1 video, then send me an email and I'll certainly get it right to you. The email address is Daryl, D-E-R-Y-L .Gulliford, Gulliford, @independence.edu. Let's do a share screen, share computer sound, optimize the video, and we'll go ahead and call up the CSE review sheet. This is a great review sheet made based upon actual student experiences taking the exam. This is advice from students who took the exam, things you need to study. So definitely it makes good advice here. I'm going to start with number 51 and finish up the review sheet in this video. Careful, the blood gas might look better. That actually applies to a patient I'm taking care of today. The blood gas actually looks better, but we've got the patient on pure oxygen, 100%, to get there. So that patient is not improving if they still need 100% oxygen. The patient is actually not better. So watch for that and don't, don't try to withdraw ventilatory support when the patient still needs a lot of oxygen. ACLS protocols, you definitely need to know all of the major protocols, and there's a good website for that, just called www.acls.net. It's got all the protocols there. My thought is to print them out and study them. Certainly the ones we definitely see on the test include the pulseless VTAC. That was VTAC without a pulse, where you go ahead and defibrillate and do the full resuscitation, and then VFib, ventricular fibrillation. There might be an occasional question or a step in the simulation having to do with a heart block, where you would use atropine. For example, third-degree heart block, where you'd recommend a pacemaker, bradycardia, where you'd recommend atropine. Those will be some of the protocols that would come into play. Narcotic overdose, definitely, you must know to use naloxone, and you might give that down the tube. We've seen a simulation or two where the patient did not have good IV access, so we would actually give them naloxone down the tube to reverse the narcotic. And the situation there is that they're going to call it not Narcan, because that's a brand name. They're going to call it naloxone. You need to know that that's the reversal agent. And by the way, you also might see romazicon. I'm going to type that on here. I hope that I've just spelled benzodiazepine correctly. But romazicon, which is flumazenil, let me actually get both of them on the same thing here. Might be given for benzodiazepine overdose. So that is relatively new to the clinical simulation, and now you know to watch for it. Naloxone for narcotic overdose, romazicon, which is flumazenil, for benzodiazepine overdose. Know the protocols for home oxygen therapy and also the infection control in the patient's home. A relatively new thing that we've seen is the cystic fibrosis patient who needs to have equipment disinfected with isopropyl alcohol, at least 70% isopropyl alcohol. And that is very important because the vinegar mixture that we've normally used over the years does not kill the bugs that CF patients deal with. So definitely know the 2 parts. Well, it's 1 part vinegar, 1 part distilled white vinegar, and 2 parts water for most patients. That forms acetic acid. And for the cystic fibrosis patient, at least 70% isopropyl alcohol. Flail chest patient, you must intubate and PEEP that patient. They're going to give you a lot of different options on how to proceed, but the flail chest patient always winds up intubated. There's no other way to ventilate them with that severe damage to their chest. Pneumothorax, needle decompression first, then a chest tube. And there's a simulation that involves a pneumothorax that happens in the air. So we're talking about like a helicopter transport or a fixed wing. And in that situation, definitely needle decompression first. You might be very difficult to do a chest tube up in the air, but needle decompression you could do. Oh, and where do you put it? Second intercostal space, mid-clavicular line. For fluid, it's the 5th to the 7th intercostal space, but for air, definitely the 2nd. I can't seem to put a regular space in there, so that's just going to be that way. Ideal body weight for vent modes and settings, you're going to use 8 milliliters per kilogram of ideal body weight for most patients, but for ARDS patients, it's going to be 6 milliliters per kilogram ideal body weight for ARDS. And I think you remember how to calculate ideal body weight, but let me just add it to the list here. Hang on. It's 50 kilograms plus 2 times the inches over 5 feet in height. Here we go. 50 kilograms plus 2 times the inches over 5 feet. And for males, we're going to add another 2. Just like that. And you've got it. Ideal body weight is how we determine tidal volume. Do not use the patient's actual body weight. I was just taking care of a patient today who is 5'5" and weighs 299 pounds, a female. And if we were to use that patient's actual body weight, we would make some really wrong decisions for the patient. So what we do is the height, and it's based on 2 times the inches over 5 feet plus 50 kilograms. Know the standards for GOLD and asthma, and those are the GOLD criteria, COPD GOLD criteria, and the asthma GINA criteria. I do not have time in this little presentation to go over all of those, but they're really important for this test. In fact, I would say you pretty much just need to memorize them. They make sense. There's nothing surprising there, but just, really thoroughly know the GOLD and GINA criteria. The Kettering study guide has a wonderful pathology section. That section is your key to passing the pathology portion of the clinical simulation exam. So what we want you to do is really study each pathology listed in the back of that study guide, the tests that are used, the treatment for each condition, essentially everything about that pathology. It's really wonderful how Kettering does that. It's just 1 or 2 pages per disease, and they give you just the diseases you really need to know. A ventilator patient that develops a tension pneumothorax. Okay. Well, first, how will you recognize that? And then how will you respond? Let's say you've got a patient with a tension pneumothorax. How will you know that? Think about it for a minute. And then what are you going to do to save that patient's life? Because they won't survive if you don't take action. Well, you're certainly going to see the peak inspiratory pressure go up. You're going to see the peak inspiratory pressure go up because tension is building in that pneumothorax. Additionally, you're going to have no breath sounds on the side that has the tension pneumothorax, and you're probably going to see the trachea shifted, pushed to the opposite side. So look for those findings, and then how do you respond? It's definitely needle decompression. Now, at the hospital, you may see the physician go right for a chest tube. And, if he's handy and everything's available to do that quickly, there's nothing wrong with that. But the correct first step is needle decompression. because it can be done so quickly by, anybody. Neurological disease could be either Guillain-Barré or myasthenia gravis, and you need to study both. Key there is monitoring the patient's respiratory strength with tidal volume, vital capacity, and maximal inspiratory pressure. Tidal volume, vital capacity, and maximal inspiratory pressure. If you will, pay close attention to that and measure those every 2 hours. Every 2 hours, you're looking for a MIP stronger than -20 to keep the patient off the ventilator. If it's less, like -15, -10, then they're going to get ventilated. And you're looking for tidal volumes at least 5 milliliters per kilogram. If it's less than that, the patient's probably going to get intubated. These patients do recover, and the thing that you need to know about that is, that they wouldn't recover if we didn't ventilate them for a short period of time during the worst of their disease. Cystic fibrosis, be sure to add DNase, which is pancreatic dornase, also known as, there's another name, DNase. Sorry, folks, I can't think of the other name, but you need to know that for the test, that you're going to add that pancreatic dornase, DNase, if the doctor has not added it. I believe that's the point of a particular case in this clinical simulation. Order a sputum culture. Anytime an infection is suspected, if they give you any hint, like a fever, an elevated white count, yellow sputum, something like that, then definitely go ahead and order a sputum culture. That's how we're going to find out what bug is causing the infection. RDS protocol for infants. A really important thing to know is that every premature infant, every infant with RDS benefits from surfactant. So go ahead and order the surfactant, okay? The situation is that, some kids benefit a lot, some benefit a little, but they all benefit, so don't hold back. Go ahead and give surfactant to every premature kid, and then ventilate them, and we're going to keep the pressures below 25. That's important. Keep the ventilatory pressures below 25. Your mode, pressure control SIMV. Pressure control SIMV is your standard mode. And if that is not working, don't hesitate to go to the oscillator. APGAR scoring and actions. I think we mentioned this in the last presentation on the CSE. But here's the way to score, and keep it really simple. If the thing that you're measuring, at APGAR, any one of those, if it's perfectly normal, the kid gets 2 points, and that will add up to 10, and the kid's in great shape. If they're 7 or above, we consider them in good shape, don't need any resuscitation. If the thing is absent, like the pulse is absent, respiration is absent, movement is absent, then that is 0 points. And then anything in between is 1 point. So add that all up. Less than 7 requires action on your part, certainly at least oxygen and, perhaps bagging, maybe even full resuscitation. But let me see if the APGAR grid, I believe it's included above. Let's see if it is. This has turned into quite a review sheet. No, it's not. So I'll tell you what I'm going to do is I will add it to this review sheet and then send it out to everyone. So there you go. APGAR scoring, important. Play. This is a direct quote from a successful clinical simulation graduate from just a few days ago. Pay close attention to wording, read slowly, and make sure you understand the situation. Tutorial systems and Kettering Sims are very helpful in terms of practicing that. Do not skip steps. You may early in the simulation think you know what's going on with the patient, and you might be right, but you would miss a lot of points by jumping to that conclusion, even if it is correct. So do not skip steps. Follow the order of management or assessment, and do not rush yourself. Oh, that's a very important point. Nobody runs out of time on the clinical simulation. I would say most students finish with a whole hour left or even longer than that. So, okay, do not fret. If you make all selections in a section, just keep moving through the test and stay positive. Sometimes, folks, the NBRC will set up a simulation so that you have to pick everything in a section. Or they may have a section where literally every option is correct. So in a situation like that, you won't know. As you're moving through the test, you won't know if you've just done something really good or something not so good. Just keep moving. Just keep moving. In every scenario, there's a way to get back on track if you get off track. And another important thing to know is that any one simulation cannot sink you on this thing. It's based on total points for information gathering and for decision making. Total points for information gathering and decision making. So any one simulation cannot derail you in terms of passing this test. Okay, well, that's the update. I hope to have another update for you in the new year. This one will be called Clinical Simulation 2, and hopefully it's helpful. I'll make sure you have the complete study guide, and I will add the APGAR as I mentioned. Okay, thank you. Shut her down over here.